Okay. Hi, good morning, everyone. Kavitha Karnik here. It is with great pleasure that I introduce our speaker this morning, Dr. Victoria Lorah, PGY5. Dr. Lorah completed her medical school at UCLA and medical school excuse me, let me start over there. Dr. Lorah completed her undergraduate at UCLA and medical school at Touro University, Nevada, College of Osteopathic Medicine. She is currently in her final year of child neurology residency and also our wonderful co-chief resident. Throughout her residency, she cultivated an interest in neuroimmunology and will be pursuing fellowship in neuroimmunology at University of Utah after completion of her residency next year. So thank you, Dr. Lorah, and we look forward to your talk on this unique and interesting subject here, neurology in flight.
Thank you, Dr. Karnik. So like Dr. Karnik said, my name is Victoria Lorah. If any of you remember last year, I gave my Grand Rounds presentation on the history of neurology. So I always like to pick topics on things that I don't know a lot about and things that are really interesting to me because it makes assembling the talk a lot more fun. So I hope it's a interesting topic to all of you as well by the end of the presentation. I want to ask for forgiveness in advance. I'm coming off of a night shift, so I might stumble over my words or be incoherent. So if anything is bad, just chalk it up to that. I don't have any disclosures. And a little bit of the reason why, oh, actually, before I get into that, specifically the learning objectives, I wanted to review pathophysiology that's made worse in higher altitudes, specifically on planes, explain what resources and tools medical professionals have when responding to in-flight emergencies aboard a plane, to discuss the ethical legal obligations of the response of a medical provider, and specifically on how to handle in-flight emergencies, with a big focus on neurology, as we are all neurologists or in neurology related fields. And the reason why I was inspired to do this talk was a couple of reasons. I had my first in-flight emergency on a plane that I got to respond to a few months ago. And there was a lot of things that I did not know going into the process, and some things I prepared myself for in advance because I had heard all these stories about my colleagues responding to in-flight emergencies. Specifically, mine was about a woman who had passed out, hit her head. And the response of not just me, but all the other medical providers on a plane was really inspiring to see how people can work together in service of a patient. I also love watching TV. If any of you have seen HBO's The Rehearsal, it's a very outlandish sort of nonfiction comedy show. And every season they focus on something different. This season they focused on plane safety. And so, with my own experience and watching the rehearsal, I was like, oh, planes, this would be an interesting talk. So, a little bit of statistics on in-flight and medical emergencies, which will be labeled as IME going forward. But the prevalence of these in-flight medical emergencies is 1 in 604 flights. This is just what's been reported between ground call and planes. So this number actually might be more in times where we didn't necessarily have ground control to talk to, or if an in-flight emergency ended up being resolved prior to contacting the ground. I've estimated 260 to 1,420 of these occur daily, and about 4.4% of IMEs require aircraft diversion, which essentially means taking the airplane off course and landing it earlier in order to have the patient receive medical care quicker. The death rate for medical emergencies on commercial flight is approximately 0.3%. And then who responds to these IMEs? In one study, they talked about 50% of them being a physician providing the aid, 25% of a nurse or emergency responder responding, and then 25% is the flight crew alone. So why do these in-flight emergencies occur? Well, of course, it could be happening just by chance. If they were on the ground, maybe this would have happened regardless. But there's four things that can affect pathophysiology on a plane. Those four things are pressure, oxygen, position, and cabin air. And we'll kind of go through them one by one and talk about what's happening in the body. The first being pressure. Commercial aircrafts have a cruising altitude of up to 40,000 feet. And cabins are pressurized to 11 to 12 psi, which basically means the body is sitting at an altitude of 5,000 to 8,000 feet. This can result in closed gas-containing spaces or non-physiological gas collections expanding by about 30%. So if it's something like the ear, which we notice when we're on a flight, our ears pop when we go up altitude, down in altitude, and that's just the natural, closed gas-containing space responding to that difference in pressure. Post-surgical air introduction can be an issue, maybe not so much in like a laparoscopy when a patient's abdomen is full, because the abdomen can probably stretch by that other 30%. But if you have neurosurgical intervention and you have an enclosed space like the skull, it may not be able to handle that 30% gas expansion. And so that can cause some problems. Oxygen is the next thing. Lower partial pressure of oxygen at cruising altitude will drop the arterial O2 saturation by about 4%. This can result in a mild hypoxia, which once again is not a problem for the healthy individual, but someone who already has a low oxygen saturation at baseline, it could affect. Position. I'm sure we're all aware of how uncomfortable flights can be. Prolonged sitting can result in hypoxia, can trigger decreased venous flow, and that can result in systemic inflammation, platelet activation, and possible thrombus development. And so symptoms of VTE might not even be present until hours to days after air travel. So if all you remember your time during an ER rotation during your medical training, asking patients about if they've been on planes recently or even prolonged sitting in a car is important to ascertain what the etiology of a specific complaint could be. And finally, cabin air. So air is drawn from the outside environment at altitude, and it's pressurized and dehumidified and then cycled through the engine compartment. This air will then circulate through the cabin, and it could contribute to dehydration or possible exposure of potential allergens throughout the cabin. Of course, if you remember during COVID, there was so much information about how clean is cabin air on in flight. And while it is clean, that does not eliminate the exposure of potential allergens. So there's this paper published by JAMA in 2018 that did a meta-analysis of all these different papers examining in-flight emergencies. And so what are the most frequent causes of in-flight emergencies? Well, you can see that syncope or near syncope takes the cake, which is 32.7%, while just pure neurologic causes alone is 5.5%. The issue with all these different studies is that some studies will put syncope or near syncope within the neurologic bucket, which sometimes confuses things and can, as we'll see later, sort of expand how many neurologic issues make up the in-flight emergency data. Gastrointestinal is only 14%, respiratory 10%, cardiovascular is 7%. Trauma is only 4.8%, psych 3.5%, allergic reactions 1.6%, OB/GYN 0.7%. It's interesting that they separate cardiac arrest out from cardiovascular issues. That is 0.2% of all in-flight emergencies, and then a various unknown bucket, 12%. So what equipment do you have available on a flight? The Federal Aviation Administration, or the FAA, has emergency medical kits aboard all their flights, and there's FAA mandated equipment and medication within these medical kits, and then some will have additional contents. So here on the left side column shows the equipment that's mandated. The right side of column is other things that you may find. So airways are important, resuscitation masks, basic tools like tape, sponges, BP cuffs, stethoscope, scissors, tourniquet, all of that is present. But you may also have other things like disposable scalpels, ET tubes, a glucometer, which I think aboard my flight we definitely had a glucometer, and I'm not surprised, or I'm very surprised that it's not included as a mandated equipment in the medical kit, because there's so many things that hypoglycemia can present with, and it's an easy fix. And of course, pulse ox, same thing. It's probably important to know what a patient's pulse ox is. So I'm very surprised that this is not mandated in emergency medical kits, and thermometers and various other things. And then these are the medications we have. We have analgesics, antihistamines, aspirin, some epinephrine, lidocaine injectables, nitroglycerin tablets, saline solution. You'll probably have one bag of a 500 milliliter saline. And that is on the left, that's mandated. And on the right is non-mandated, but are things that you could potentially find. So if you look here, steroids, benzodiazepines, other and NSAIDs, these are present in some of them. Interestingly enough, if you notice epinephrine auto injectors, I'm sitting in one of the focus rooms, so the lights just went off. Epinephrine auto injectors are some of them, but you still have epinephrine injectable if you were in a situation where you would have allergic reactions. So, per the CDC Yellow Book, the number of first aid kits available on an aircraft correlate to the number of seats. So, if you are on a big, long international flight and you're responding to a neurologic emergency or just any medical emergency on a flight, you can remember that you have not just one bag, but potentially four bags if the flight is large enough to work with. So, for example, if you have a patient who is requiring multiple IV fluid bags, if you run out within that first bag, think about how many or what resources are available, how many kits are available, and you can pull from those as well. Other resources on the flight are the flight crew. They are trained in CPR, they're trained on how to operate automated external defibrillators and for assessing cabin security risks. They can also establish contact with ground-based medical experts. So if you are responding to an emergency, it's important to know that you will have a doctor that you can communicate with on the ground, contacted by the flight team, and they can give you guidance on the next steps if you are unsure of what to do. Interesting enough, during my research, I saw that until the 1930s, you had to be a nurse in order to be part of the flight crew. But they got away with that credentialing, interestingly enough. Some considerations about diversion. Ultimately, medical responders aboard a flight do not make the decision of diversion. It's up to the pilot. However, they will probably take your medical expertise into account. And so it's important to know, is this a patient that requires urgent medical attention, or is this a patient that can be stabilized and we can continue the course? Things to consider with diversion specifically is the cost. It can cost from $20,000 to $725,000 per diversion of the flight. Also, too, if the flight is just taking off, you have to think about the environmental impact because it is not safe to land with the amount of fuel that a flight takes off with. So that fuel must be released for a safe landing. Also, too, you have to think about safety and resources. If you're on a transoceanic flight, it's probably going to be impossible to land the plane. And even if you were flying over somewhere, is where you're going to land going to have the medical resources that's going to be helpful to the patient? If not, it's probably better to keep them stabilized and proceed to the destination. But of course, that is a conversation that takes place between the flight crew, the pilot, and the medical professionals responding to the flight or the in-flight emergency. So, ethical and legal obligations. So, are you required in the US to respond to an in-flight emergency? The answer legally is no. In other countries, yes, you are required. But what about your level of protection? Fortunately, in 1998, the Aviation Medical Assistant Act was passed in the US, and this protects medical personnel from damages in federal or state court for providing good faith medical care on a flight. Of course, this does not cover gross negligence. If you are not licensed or qualified to perform the medical care that you're performing on the patient, or if there's willful misconduct. So this is something to consider if you're coming back from an international flight, you've had a few drinks, you've taken a pill to help you sleep, you may not be in the best place to administer medical care. Of course, I'm not going to tell you that if you are the only person aboard an in-flight emergency who can provide care, not to provide it, but that is something to think about because in that situation, you could be legally held liable if something goes wrong. So there's no equivalent law for international travel. So there's no protection in international travel, but some countries will require their physicians to respond to in-flight emergencies. I was looking a little bit into this. In the one laws in Australia or Europe, but it doesn't necessarily specify if that's for medical licensure within Australia or Europe, or if you were flying over Australia and Europe and you were a physician. So use your best judgment. So getting a little bit more into the nitty-gritty, specifically thinking about neurology on flights. Servin et al. Wrote this paper in 2002. Is there a neurologist on this flight? And it reviewed in-flight medical emergencies based on Northwest Airlines, which I don't believe exists anymore, and the Mayo Clinic air-to-ground consultations. This paper encompassed about 200 or 2,042 medical incidences, with neurology symptoms being the largest category of medical incidences. So you see here 31%, and this is including dizziness. So you could think about that as potentially pre-syncopal presentation. Seizures, headaches, pain, interesting that they include pain in there, and cerebrovascular symptoms. And neurologic symptoms made up of 34% of all diversions, with an estimated cost of diversions due to neurologic events specifically up to $9 million. Of course, we remember the phrase time is brain. And so if we have patients that are presenting with neurologic symptoms, especially those of stroke-like presentation, it makes sense that we're the ones to divert the plane because we want to get these patients care as soon as possible. There's another article in the New England Journal of Medicine in 2013, which talked about outcomes of medical emergencies on commercial airline flights. Peterson et al. Report syncope made up the 37.4% of all in-flight emergencies. And out of all in-flight emergencies reported, so not just syncope, but out of all of them, 25.8% required transportation to a hospital by EMS, 8.6% were admitted, and 0.3% died. The most common trigger for admission was possible stroke. Once again, that makes sense if we're concerned for stroke workup. But it's interesting to see that the most common trigger for admission was a neurologic cause. This paper in 2018 was an update of the original 2002 paper from Dr. Servin. Is there a neurologist on this flight? And he reiterated the statistics for neurologic symptoms on a flight, which included the syncope, seizures, psychiatric agitation, stroke, headache, and ear pain. And he talked a little bit in this paper more about why in-flight neurologic issues are so common. As we discussed earlier, there's four main areas that affect the body: pressure, oxygen, position, and cabin air. But in addition, we know that anytime the body is in a stressful situation or there's emotional stress, it can exacerbate neurologic symptoms. And that could include a recrudescence of prior stroke symptoms, headaches, seizures, or syncope, as well as psychiatric issues. And so worsening flight conditions over the years, increased security barriers, flights being overbooked and packed, reduced personal space. We know the luxury of flying has kind of gone up to the wayside over the years. And so hitting costs for everything. You don't sleep well. Most people have an increased diagnosis of mental health issues that can make this worse as well. So those are just some thoughts as to why in-flight neurologic issues are so common. And then I wanted to go back a little bit and focus in on this paper, Neurology in Flight, 2011, Neurology at the Airport. This was a study that took 77 patients who at the Madrid airport were contacted, or at the Madrid airport ground consultations with neurologic symptoms specifically in Madrid. And so 77% of these patients had neurologic symptoms and were included in the study. And if you look at table 1, it breaks it down to what their data showed. So 39 of these patients presented with seizures, that's 50%. 23% of patients presented with stroke symptoms, and then 26% had other category. If you look at all the patients involved, there's a male predominance of 76%. Vascular risk factors, past seizures, drugs, or alcohol use contributed to some of these neurologic emergencies. Flight duration, longer flights made up the majority of these in-flight emergencies with 61%. And 41% were during the flight, 58% were after landing, but while the patient was still on the plane, and unknown in 5% of the cases. Going through a little bit more of their data that they collected, this table shows the classification of seizure presentation, adapted from ILAE 2006 criteria. So the 41% of patients, 39 plus the two, I think two that were considered other, were filtered into this category. And it looks like 48% were idiopathic or cryptogenic epileptic seizures. 39% were provoked or acute symptomatic seizures. So either exacerbated or triggered by drugs, alcohol, cocaine. First paper I've seen that specifically calls out cocaine, or other issues going on in the body like strokes or massive PEs. And then there was a small little bucket of psychogenic non-epileptic seizures present here. Table 3 focuses in on stroke subtypes or etiology, and it's pretty equally divided. 8 patients presented with an ischemic stroke, 8 patients presented with intracranial bleeding, and then there was 2 patients that had transient ischemic attack. And then the clinical features of patients with other diagnoses that were sort of in that third category outside of seizures or stroke. That was about 26% of the patients in this study. And some of the things that were focused in on was drug toxicity, non-organic symptoms, syncope, neuropathy, delirium, neoplasms. This paper also had a really good flowchart of things to think about when you are responding to in-flight neurologic emergencies specifically. So for stroke, seizures, or altered mental status, the number one most important thing to do after making sure the patient is safe, making sure their ABCs are all there, is to check the patient's blood glucose, which is a little bit what we were talking about, right? FAA does not mandate a glucometer in their medical kits, or at least to not what I've seen in their updated publications. So as of 2018, it was not mandated. However, I think most kits nowadays, from my experience and my conversation with other people, do include a glucometer. This is very important because hypoglycemia is a great mimicker of neurologic issues. So if you are looking for a patient or examining a patient who you're concerned has a stroke, ruling out hypoglycemia is important, scaling them with the NIHSS stroke scale, and then also if considering diversion. So if you are concerned that this patient has a stroke, then it is absolutely imperative that this patient seek immediate medical care. And so another thing important to tell the in-flight team is that if diversion is necessary, it's important to make sure that they know the seriousness of the issue because your gate could potentially be open faster and EMS can be waiting to take the patient off the plane and get them medical care quicker. Seizures, making sure the patient is in a safe position, which could be very hard on a flight with limited space. We found on my in-flight emergency, the best place to work on our patient was exactly where she fell, which is by the emergency exit in the bathroom. So there was a lot of room on the ground. So if you can have patients have in-flight medical emergencies in a spacious location, please tell them to do so. Seizures are going to be really important to manage. Some of those kits may have benzos, but once again, not mandated. And it's also important to ask the patient's travel companions, if there are any present, the patient's medical history. You can, if you feel comfortable with it, which I'm sure you would in this situation, looking through the patient's belongings to see if they have a seizure action plan or rescue medication to administer. And then if you are in a position where you do see benzos in the medical kit, you can administer them. And of course, making sure that if a patient is in status, that you consider diversion of the flight. Altered mental status, same thing. You want to check hypoglycemia. You want to make sure the patient is safe, deliver oxygen if needed. Once again, the medical kits may or may not have a pulse oximeter. I think that falls into the category of the glucometer, where most medical kits these days do have a pulse ox. And so you want to make sure that those things are checked and make sure the patient is safe. If their depressed consciousness is sustained and they're unresponsive to glucagon and we don't have a secure airway, then you definitely want to make sure the flight is diverted. And then if you're concerned about possible drug intoxication or a psychiatric emergency, then it's also important to consider diversion of the flight. So this paper also talked about suggested medical kit equipment and medications for onboard neurologic problems. And if you see here, this is what they recommend. The only thing that we do not use in the US is the metamizole. That is not something that that the US has approved. But if you look here in the equipment, you see that the oropharyngeal tube or oropharyngeal airway is present. But you have some medications that aren't considered part of the FAA mandated medication list. And so that is something that we could probably improve upon adding to that. Like I said, there could be an update. I was not able to find an update if that was present. And then just wanted to touch base quickly on this paper that talked about air travel and seizure frequency, specifically for patients with epilepsy. There were 37 participants in this study, and it was reported that 1/4 of the participants recorded increased seizure frequency after air travel. This quote I pulled directly from the paper says the study indicates that the higher the seizure rate prior to flying, the greater the likelihood of an increase in seizures after air travel. So the 1/4 participants who had increased seizure frequency after air travel were likely to have had higher rates of seizure prior to flying. And the thought of this is, anything that contributes to stress, sleep loss, possible O2 desaturation, stress in the mind, stress in the body can result in a seizure trigger. There was no correlation between post-flight seizure frequency or direction or distance of the flight. So if you're flying north or south, or if it's a long flight, short flight, it doesn't really make a difference from this study. And then just to review this graph here. So the flight was taken on day 8, and this was a sum of all the seizures reported. So you can see the general trend a week prior to the flight. This is what the seizure frequency was like. And then a week after the flight, this is what the seizure frequency was reported to be. So you see there's a clear increase in seizure frequency reported amongst the 37 participants. Last thing regarding neurology and flight specifically, I wanted to point out this article written by John D. Hastings. He was a board certified neurologist and aerospace medicine physician, and he served as the Aerospace Medical Association president and a consultant for the FAA. He passed away in 2021, but he contributed a lot from all the obituaries and things I read about him to neurology care, specifically aboard flights. And he had this document that I was only able to find a PDF of. I don't know where exactly they published it, but it's a pretty good document with very quick reviews regarding the following things. So I just recommend you guys taking a read of it if it interests you. But it talks about TIA, stroke, migraine, syncope, dizziness, recent neurosurgeries, neurobehavioral considerations, and mobility, bowel and bladder considerations. So let's get a little bit into the non-neurologic issues. So if we're the only people to respond to a medical emergency aboard a flight, unfortunately, that might mean that it's not a neurologic emergency. So what do we do? JAMA came out with a great article called In-Flight Medical Emergencies, a Review, that has these cards that kind of walk you through what a presenting symptom is and the next steps. So if you are like me and likes to be very prepared and you travel quite a bit, then this might be helpful for you. So this article has all of these headers of presenting symptoms in order of most common to least common, and talks about the initial assessment, management, and expected course for the flight for each of the main buckets. So you see here we have syncope and near syncope, our #1 cause of in-flight medical emergencies, cardiovascular symptoms, GI symptoms, stroke-like symptoms, respiratory distress, seizures, trauma, allergic reaction, psychiatric symptoms, OB/GYN emergencies, substance abuse and withdrawal, and cardiac arrest. So, for example, going through respiratory distress, we see the initial assessment, things to think about, questions to ask, use of tools or equipment you have available. I would probably add to this and checking the pulse ox, maybe using the stethoscope that is mandated in the bag to assess their lungs. And then it talks about what steps to do next and what you can expect as complications if you are in charge of medically stabilizing the patient till your flight lands. So you can cut these up, put them in your travel bag, utilize them if you're ever stuck on a flight and have to respond to these type of emergencies. And other things to think about when you're responding, making sure you take a deep breath and be confident in your skills as a physician. This is probably more so for residents and other learners, not so much for all of you wise attendings who've been doing this forever. You want to make sure that you introduce yourself to the patient if they are conscious. In addition, making sure you look to see if they have any travel companions who may be able to fill the gap on some of the medical history and give you a better idea of what you need to assess. Also, too, if it's an international flight, it's important to have the patient's primary language taken into an account. So if a patient is speaking a language that you are not familiar with, maybe asking the crew if they understand the language, and that way you can set up better communication. Make sure you utilize your in-flight crew. Like we said, all the flight attendants are know where all the kits are. They know how to respond. They will establish connection with air or with ground medical care if needed. They'll be in communication with the pilots, and they'll be able to assist with things like CPR. And when I was on the flight, I was just, we didn't have gloves in the box, and so I was asking the flight crew, "Can you hand me boxes? Can you give me tissues?" Things like that. And it was very helpful to have them. Also, too, I was very lucky to be on a flight where we had many different types of providers. There was an internal medicine doctor, there was an oncologist, there was a PA, and myself. And so it was great to have a team of people who had different strengths. For example, my strength is not in placing IVs, and but fortunately, we had an internal medicine doctor who was older, who had frequently placed IVs in their training, and so that was really helpful to have them on. And of course, if you can move the patient to a space where it's going to be more quiet, more private, that is ideal. If it's not safe to move the patient, of course, then you do the best you can with the space you're given. And then it's important to also document your clinical encounter. These medical kits will have a sheet provided for you. I wasn't able to find the exact sheet, but this is a pretty good medical incident report I found online. And this talks a little bit about patient information, details of the report, what they presented with, what injuries on your examination that you're able to see, and what things were done. Because likely, if their EMS is coming on board the plane when you land, they will be expecting a sign out from you. And so being able to not just provide them information about the things you did, but to provide them detailed information written down in the times that you did them will be very important for their care and their communication to the accepting medical team at whatever hospital they're taking the patient to. So all that's very important. So that was a lot about how we as medical responders focus on caring for patients who have these in-flight emergencies, but how can we better set up our patients for flights? The CDC has not just a great, they have multiple great resources for patients with chronic illnesses or patients who require specific medications or specific medical equipment. And so the Travelers with Chronic Illnesses page is great resource for patients and also great resource for physicians in counseling their patients about what to expect on flights. Specifically looking at CNS disorders and spinal issues, this article talks about 5 main categories: cognitive impairment, cranial surgery, seizure disorders, strokes, and TIAs. Some important things to highlight from this. It is all important to let your patients know about being flexible with their travel plans. If your patient has cognitive impairment, it's probably not safe for them if they are having an acute psychiatric issue, if they're having worsening of their neurodegenerative disease. If a patient in cranial surgery, remember we have to think about that 30% air expansion that can happen in an enclosed space with introduction of air. So it takes about 1 month to clear cranium air. And so it's probably not safe for a patient to travel within that time of the surgery. And so so you need to get medical clearance from the surgeon specifically. And then seizure disorders, if a patient's having a lot more seizures 24 hours prior to their departure, chances are they're going to have a lot more seizures on the flight or afterwards. Strokes, if supplemental oxygen is needed before the flight, it will be needed on the flight because of that 4% drop in oxygen saturations across the board. And then, of course, TIAs, it's important to assess patients' risks. If they have high risk factors that might precipitate a actual stroke, you would hate for that patient to be on a flight when that stroke happens. The article also goes into resources for patients with specific medical conditions, and I wanted to highlight just 3 here. So the Epilepsy Foundation has traveling tips for patients, and this is important to review with our epilepsy patients. If a patient is an adolescent or an adult, then you want to ensure that they are carrying their rescue medication with them at all times and that their travel companions know how to administer it. It's also important for our patients who are traveling alone to know that it's important that their medications and seizure action plan are readily available. This is up to each patient individually, but it might be worth disclosing to an in-flight crew member about the condition, about what to do if it happens. So letting your stewardess or your flight attendant know, I have seizures and I have my seizure rescue plan and my seizure medication in a bag. So if anything were to happen, it is available in this bag and you have permission to use it. That would be, I'm sure, putting everybody's mind at ease. And then also accounting for known triggers. If being dehydrated or having poor sleep is a known trigger for our patients, it's important to let parents know. Make sure we have enough food and water packed for the flight. Make sure we have things that are going to make sleep more easy. If you become ill, it might not be best to travel with your child because your child might have an increased risk of seizures on the flight. Multiple sclerosis. So it's important to recognize that although there can be true exacerbations of multiple sclerosis, for which you can get an oral prednisone dose if you're traveling somewhere with limited medical help, any type of stress on the body can cause a symptom flare that should resolve within a day. So it's important to talk to our patients who are flying. Hey, stress, heat, fatigue are known things that cause temporary symptom flare. All that could have happened on board a flight. If you were concerned about these symptoms occurring within a 24 hours of traveling, give it a little bit of extra time before going to seek medical care. And that might give the patient some ease. Also, too, if a patient takes injectable medications, this is across the board, not just for neurologic conditions, but it's important to have the patient pack their medication in temperature-specific guidelines, and will likely need a physician's note for bringing needles on board. I don't think you'll be able to make it through TSA with needles, but I've never tried. So if you or someone who has tried, let me know. Also, too, preparing our flights, our patients for flights who have dementia. Most of us here are pediatric neurologists, so we don't have to deal with this quite frequently, but we may have ailing family members who have dementia. And so things to think about for them is that we want to try to stick to routines as much as possible. If you know a patient or person you love gets worse towards the end of the day, it might be better to schedule flights in the morning. It may be good to schedule flights during the times that they're typically up, and making sure that they have all the essentials with them. Meds, travel itinerary, a change of clothes in case of accidents, water, food, and you can also consider enrolling them in a wandering response service. That's just not for flights, but it would be hard to navigate if someone in a crowded airport, you get separated from them and don't exactly know where they are. And across the board for all patients, it's very vital that we encourage them to keep all of their medications with them in their carry-on, off because of the off chance of their suitcases and luggage being separated from them, being lost, being delayed. It's vital that they have their medications to take at the same time, especially for our seizure patients. One last thing I wanted to highlight was medical equipment. The TSA Cares website has great resources for people who have disabilities. Whether or not it is implemented well, I do not know. But this is important for our patients who are bound to wheelchairs, who require walkers, who require other aids, or patients who have implantable devices, of course, like our VNS, our DBSs. And so this website has drop-down categories here that talk a little bit about what things are needed for clearance, and also how to make the move as smooth as possible. I wanted to highlight Shane Burkaw and his wife Hannah Burkaw. They have a YouTube channel called Squirmy and Grubs, and Shane is affected with SMA and spinal muscular atrophy specifically. And he's a speaker, author, and disability rights activist. And him and his wife frequently talk about the pains of travel, given that he's dependent on wheelchair use. And so something more human thing to consider for our patients who have to wrestle with insurance companies to get this expensive equipment. It's very frustrating for them when airlines do not take care of that equipment. And so they talk a little bit in a humorous fashion about some of their frustrations with medical equipment being broken and how best to communicate with the airlines in order to secure their medical equipment. And so that might be something to consider directing your patients to if they feel a little alone and frustrated that they aren't the only ones. And hopefully, Shane and his wife are continuing to use their platform to bring attention to that and to encourage airlines to take disability care more seriously. So, in conclusion, I hope this talk gave you some more confidence about responding to in-flight medical emergencies, specifically reviewing the pathophysiology of air travel, tools and medications and resources available on a flight, and how to respond to specific symptoms. And then hopefully with reviewing travel plans with your patients, will give them confidence to travel despite their medical conditions. Here are my references, and I wanted to thank you all for listening to my presentation and give a special thanks to Dr. Mangum, who helped review my presentation. Thank you. Anybody have any questions? Let me see if
Hey,
I can.
Victoria. Really great talk, very helpful information, and thank you for covering this topic. One of the questions I had was, I just remember this being talked about, I think, during our grand rounds when I was a med student. So this might have changed, but when you respond to an in-flight emergency, sometimes airlines try to offer things like rewards and this and that after you've responded. And what I remember taking away from that talk, which is from, I think it was from someone who had a secondary law degree, was don't take those rewards because then it negates your kind of action and kind of good faith and all of that, and actually puts more liability on you should anything happen. Did you come across that at all in your reading and preparation for this?
No, nothing about that. I did see a case of somebody who did try to sue somebody who gave them medical care upon a flight, but because of the federal and state law of that 1998 act, the case is probably going to be, or probably was settled outside of court because they don't really have grounds for the gross negligence or the willful misconduct. That are the two exceptions of that. And so I don't even think it'd be possible to make it there unless there was a concern about that. Each flight, I've talked to quite a few people in preparing for this talk, and every one of them said like, oh yeah, the flight, they gave me like a little bottle of champagne, or they gave me some snacks, or they gave me a flight voucher, things like that. And I don't think it's necessarily bad to accept those things. My in-flight neurology, I'm just going to shout them out. American Airlines, they didn't even thank me for my service. And so I was a little perturbed by that. But of course, at the end of the day, we don't do it for thanks or reward. We do it because we care about the patient. But I think nothing I found said that you can't accept those little treats as a sign of gratitude. Of course, if it's bigger monetary things like vouchers, maybe that might be something to consider, but nothing that I saw in my research.
Thanks, and I agree with you. We should be doing it because it's the right thing to do,
Yeah.
not because of the rewards. And just like you, I've never actually been offered any rewards for the two times I've responded. But
Yeah.
just an encouragement to others. I know it can be nerve-wracking or you're tired after travels, but please respond to in-flight emergencies. I've been on two international flights, one in residency and one, in my young attendinghood, and it's frightening when no one else raises their hand on that flight to assist with an emergency, no matter how big or small.
Yeah. And you can be encouraged that the majority of them are things that don't necessarily require immediate that require diversion or anything like that. So you can say statistically, I'm not going to be walking into something really bad, if that makes you feel any better.
Hey, Victoria, a really great review of this important topic that I think eventually will touch all of us at some point during our travels. Um, I've had this come up actually quite a few times during my travels, and the most recent time was kind of a little bit amusing and somewhat frustrating. Typically, when you get called to these, just like in your case, there's other medical professionals that are there, and you go through the list, and you're just hoping that someone's an ED doc or paramedic or something that is accustomed to responding to general emergencies. And it's always frustrating when, as a child neurologist, you're the most qualified person on the plane for whatever
Yes.
the medical emergency was. But the last time got called, went to the back of the plane. I was the only one responding, and there was a young teenage lady on the ground shaking, and I thought, wow, what are the chances that I'm actually going to encounter a seizure on the plane? And I identified myself to the mother that I was a child neurologist. I was very familiar with seizures. And she says, "Oh, you're a child neurologist. Great. Susie was just diagnosed with a functional neurologic disorder
Oh
and just left the
no.
hospital." I said, "Okay, where's the Ativan?" And it's super frustrating that most of the flights don't carry benzos of any sort. And this child could really have benefited it as well as the mother. And so as soon as the mother told me and I evaluated, it was clearly a non-epileptic seizure event. I told the flight attendant, whatever you do, don't divert the flight. And it was a long flight. And they were already on the phone with the ground crew and the pilots, and they diverted the flight.
Oh my goodness gracious.
So,
Oh no.
but anyways, benzos uh, are much needed for a lot of things, including, Harlori's tragic case that she talked about with status that wasn't able to be controlled in flight, and it's I can see the regulatory perspectives of having controlled drugs on a plane, and I'm sure that's what the barrier is for some of the airlines, but hopefully that it gets addressed at some point.
Well, I'm sorry they didn't listen to your expertise, Dr. Wolfong. One thing I wish I would have gone a little bit more into detail in was the legality or the ethics of utilizing other people's medications on a flight. So I can't really speak to that, but I imagine on a flight that large, perhaps someone is carrying rescue medication for seizures or potentially a benzo for anxiety. And so, do we ask people to use their medications for that if it's an emergency? I don't know if you're legally allowed to do that or if we as doctors should even do that, but that's probably something I would look into next if I were to update this talk at any time.
Yeah,
Hi,
hi
Dr.
everybody.
Lowe. Oh,
Oh,
go
sorry.
ahead. Go ahead, Jay.
Please. Okay. Just real quick. The only person probably less useful than Wilfong on a flight is me. I think no one gets up and says, "Is there a neurosurgeon on the plane?" But I do have some knowledge about Good Samaritan laws and physician protection. I was a firefighter and paramedic almost my entire life before medical school and during medical school. I have a couple funny stories over the years of things I've been called to help out, including a rodeo in Moses Lake, Washington, a couple of years ago before I moved here to Arizona. But because Lori asked some questions, and so I do have some firsthand knowledge, and I also, for better or for worse, have done some defense work for physicians who've been accused of malpractice over the years. You are almost entirely and 100% protected by Good Samaritan laws in almost any circumstance, unless there are a couple like weird exceptions to it. One is if the things you do are considered reckless or grossly negligent, which no one here would do. I mean, things that are like so wildly outside the standard of care that it would not be hard for
Hendrix
them to.
or
Yeah, it would just not be hard for them to find someone to say what you did was crazy. The other thing that's a little weird is if you are in a medical setting, like not like in something that is a medical setting, and you start practicing like real medicine as a good Samaritan, then yes, you are open to standard of care stuff. And then the question about, Hillary asked about, getting gifts. And this is a good question. I'm going to actually ask, I have a couple good friends that are lawyers, one of which is a pretty high up lawyer in the state of Washington. So I'm going to ask him what he thinks, but I am almost certain that that would not be considered compensation because you are not their employee. You're not filing a 1099. It is clearly a gift. And so I would say, like, I don't know. I had to see if there's like precedence or if anybody's ever been sued over this, but like I would say, I know no one does it for it, but I see no reason why you couldn't accept an in-kind gift from an airline because like they disrupted your travel. Maybe they stressed you out. Maybe your family was with you. I just don't think there's anything wrong with that. And I really don't think that increases your liability because I do not think that is considered compensation. I think that any reasonable judge would consider that a gift, for your kind actions. But thanks for the talk. That was super interesting.
Thank you.
That was great, Dr. Laura. I really enjoyed it. And the one thing I really wanted to highlight is how important it is in terms of what you said to prepare our patients. And I think we are in that unique position that if our patient says, "Oh yeah, we're flying, across the ocean, or we're flying all the way to Orlando from Disney World, or we're flying whatever," if they have epilepsy, or if they have migraines, or they have whatever, they have their rescue meds, they have them with them. The concept is there, but you're right. They always forget where it is and how to use it, especially families who don't use them very often. So just reminding people of that. And also, since I'm on the Make-A-Wish board, I would remind people that Phoenix sends a whole lot of people on direct flights to Orlando because that's where they take their Make-A-Wish to Disney World. And so if you're ever on a plane, Phoenix to Orlando, just know that there's probably somebody on there who might require assistance, although the Make-A-Wish kids are really, really well prepared. They have to go through very rigorous ready to fly guidelines. So those families are generally ready and have all their things there. So thank you for doing this. This is great.
Oh, you're welcome. I was a little selfish. I just picked a topic that would be fun to research. So, but yeah, I definitely had a patient who mom wanted to take her to South Africa and visit family, and she's like, I don't know what to do. Like, what if I use my first rescue? Then what? What if I use my second rescue? Then what? And so it's hard to counsel them because at a situation where they can't swallow extra doses of Keppra because they're still seizing, that I think it's important to make them aware that that is a possibility. And so because I imagine that might influence their decision to travel. Yeah. All right. Well, thank you everyone so much. I hope you have a good rest of your week. And since I just got done with the night shift, I'm gonna go get some sleep. So
There
hope
was
everyone.
one comment. There was a question from Jason
Oh,
Abbott, if you saw that,
let's
about
see. What did he
aspirin.
say? If concerned for a stroke, should we consider giving aspirin on a flight? That is a great question. I'm not entirely sure. I think I would probably um, hold off only because we don't know the nature of the stroke. And so I think if you're just concerned for stroke in general, that patient needs to be diverted and requires medical workup. But I think things you can do in the meantime would be um, giving them oxygen, things like that. Oh, Dr. Gerard got a bottle of wine once. Oh, which the person sitting next to me happily accepted. Was that your husband, Dr. Gerard? Or was that somebody, another flight? Nope. Perfect. Um, yes. All right. I think those are all the questions. Did I miss any questions? No, perfect. All right. Thank you so much. Have a good rest of your day.